everyone. Today we will discuss regarding breast carcinoma. I divided into two portions. This week we will take part 1. Recently I encountered this picture in social media and due to this COVID scenario. But this picture has reminded me our scientist Albert Einstein and Stephen Hopkins. It clearly suggests that development and science, we are deteriorating or we are improving. Stephen Hopkins has rightly said that too much dependence on technology will ruin mankind. So with development of technology, we are going to be deteriorating. So this is a very indicative picture. Education. True education. What is true education? So it helps to understand our conflicts, to understand the stupid ways of our mind, to end our hurt, and thus to optimize life and not to be victim of situation. So are we educated? Are we educating in this with science and technology? If education is not able to us doing this, then this is not education, this is training. So I think we have to think about these quotes are said by Hopkins and Einstein. So I divided this topic in two portions. Today we will take first portion. We will have a brief history of breast cancer therapy, epidemiology, risk factor and preventions, pathology, diagnosis, including clinical pictures and investigations. Later on, next week, we will see remaining part of the lecture, staging, treatment, and special clinical situations. What is objective of this presentation? At the end of this presentation, everyone is able to understand, everyone has knowledge of what. So in simple form, I can tell that if after this presentation, who is attending is have feeling like this child, I got it, then this is our objectives. This is our final objective. Let's start from brief history of breast carcinoma therapy. So it dates back to 3000 to 2500 before Christ. Two documents are available, the Smith Surgical Papyrus and De Medicina by Celsus. Later and followed by quotes and study of Galen, Morgagni, and then history goes on. So from 3000, 25,000 BC, so it is incurable. Once it is happened to in 2000, in 21st century, the breast carcinoma is considered as a potentially curable and has having 20-year survival rate. So this is the development of science. So Hippocrates, Galen, Leedran, Muller, Stuart Helstar, these are all our scientists who has done very appreciable work, and these are the part of golden thread in development of management. Out of all the Bernard Fisher has changed the concept of humoral theory by Celsus to alternate hypothesis that breast cancer was a systemic disease. It is systemic disease. Let's think about epidemiology. So, if you look at the epidemiology of breast carcinoma, incidence are more in American, Australia, New Zealand, and European countries, and Afro-Asian countries have low incidence. So, it suggests development is proportionate to breast carcinoma. We will see risk factors, various prevention and screening. So, looking at the epidemiology as compared to American data, so 1 in 8 American women is developing breast carcinoma. In latest 2018, there are 252,701 new cases and 40,000 deaths in USA. As compared to those data in India, so which is published in 2016 by Bharat Rangarajan et al. In South Asian Journal Cancer, overall 1 in 28 women likely to develop in lifetime. out of which 1 in 22 in urban and 1 in 60 in rural area. And it constitutes 40% of all cancers. So as compared to America, here incidence is less. In 2018, in India, 162,468 new cases were noted, out of which 87,000 death. So it suggests low incidence, high mortality. Reason is poor or defective or absence of screening programs and patients' exposure to multimodality of less exposure to multimodality management, and so that mortality is high. So in 2012, breast cancer was the most common cancer in women in India, way ahead of cervical cancer. So rate of the breast cancer is increasing more rapidly than cervical cancer. So after 2012, the breast carcinoma is the most common malignancy in Indian women after cervical cancer. So incidence begins in rise in early 30s and peak at 50 to 64 years. 52% in 40 to 49 years of age in India. So worldwide death is 1.38 million due to breast carcinoma. Risk factors. These are no hormonals and non-hormonals. Considering age, as age increases, rapid incidence increases until early 60s, peak in 70, and then it declines. Family history and genetic factors are very important while we considering breast carcinoma. Breast or ovarian carcinoma depends on BRCA mutation. 5 to 10% of breast carcinoma are hereditary carcinoma, out of which first degree relative less than 50 years, risk doubles. 2 first degree relatives, risk triples. Male breast carcinoma, there is more increasing risk. Genetic testing is imperative. So risk calculation, there are famous Gale models and Claus models, and in USA, Gale model is highly commonly practiced. This model constitutes other factors versus family history and genetics. So Claus model, other than these risk factors, also consider family history and genetics. Third factor is hyperestrogenemia. So early menarche, less than 12 years, or late menopause, more than 52 years. Nulliparity, obesity, these all are things which causes increased exposure to estrogen in lifetime. More duration of exposure to estrogen, then there are more chances of development of breast carcinoma. Past history of any malignancy like contralateral breast carcinoma, ovarian and endometrial cancers, the incidence rate of breast carcinoma is more. Late first full-term pregnancy after 30 years, again the rate is increases. Alcohol, high-fat diet, again causes increased exposure to estrogen due to conversion of endosterone to estrogen by adipose tissue. Benign breast diseases, especially proliferative diseases, without atypia, relative risk is 1.5 to twice. With atypia, 4 to 5 times relative risk. High socioeconomic status is also important, and rate of breast carcinoma is more. Radiation exposure in any form, just like mental, submental radiation exposure in lymphoma, thyroid cancer, there are relatively higher chance of development of breast carcinoma. Hormone replacement therapy, especially combined estrogen and progesterone, is increases more than estrogen alone. Smoking and OC pills do not increase risks, but long duration and fast breastfeeding has a protective effect. So these are the risk factors which we consider in development of breast carcinoma. Hereditary or familial breast carcinoma incidence is 10%. These are BRCA, gene HER2 or PLAG, neonomic PLAG, including Peutz-Jeghers syndrome, Li-Fu-Many, ataxia cholangioplasia, Cowden's, and HNPCC. At least 60 to 80% lifetime chance of developing breast carcinoma and about 30% chance of ovarian carcinoma. So BRCA1 and BRCA2 was major portion of hereditary or familial carcinoma. The chromosome 17 in BRCA1 associated carcinomas are invasive ductal carcinoma, poorly differentiated, hormone receptor negative, early age of onset, and bilateral. Associated malignancies are ovarian, colon, and prostatic carcinoma. So BRCA1 is considered as a high risk, high risk carcinoma. BRCA2 is a chromosome defect in chromosome 13, and these carcinomas have again invasive ductal carcinoma. These are well differentiated, organ is positive, early age of onset, bilateral. Associated malignancies are ovarian, colon, prostate, pancreas, gallbladder, stomach, and melanoma. Prevention. NSABP, the National Surgical Adjuvant Breast Project, conducted first breast cancer prevention trial P1 in 1992. This was the major study for prevention of breast carcinoma, in which they studied chemo prevention using tamoxifen given in high risk ER positive women with no past history for and given for 5 years. 50% reduction in non-invasive and invasive carcinoma compared to placebo. Certain or prevention modalities are risk reducing surgeries, in which prophylactic mastectomy and Salpingo oophorectomy in positive family history and BRCA gene mutation can be done. Screening. Screening is considered as an important modality to reduce incidence of breast carcinoma. Screening can detect cancer earlier, and breast carcinoma is potentially curative carcinoma. So, if we have effective screening, we can identify at early stages. At early stages, if we manage the breast carcinoma, cure rate is nearly 100%, or 25% survival rate is more than 90%. So, American Cancer Society recommendations are at the age of duration of 20 to 39, self-breast examination, clinical examination, so monthly every 3 years, 40 to 49 years of age, breast self-examination monthly, clinical examination yearly, and mammography every 1 to 2 years. 50 and older, again breast self-examination monthly, clinical examination yearly, and mammography yearly. So, important is age group between 40 to 49. In high-risk patients, positive family history, BRCA, BRCA2 gene mutations, we can advise mammography every 1 to 2 years. Otherwise, more than 50 screening mammography should be routine. So, between ages of 50 to 69 demonstrated 34% reduction in mortality from breast cancer by screening mammography. Now we will discuss pathology. So WHO classification, Bloom-Richardson grading system, Nottingham prognostic index, and spread of tumor. Looking at the classification, we can divide broadly into in situ carcinoma, invasive carcinoma, and Paget's disease of nipple. In situ carcinoma includes ductal carcinoma in situ, lobular carcinoma in situ. Invasive carcinomas are ductal carcinoma, lobular carcinoma, tubular, mucinous, medullary, papillary, metaplastic, and inflammatory carcinoma. We will see one by one. So first we will see carcinoma in situ. Two types are lobular carcinoma in situ and ductal carcinoma in situ. Nowadays, in latest 8th edition of HSCC classification, LCAS is not considered. It is considered as a nearly benign disease, so it is now not included in the staging system. So, looking at the comparison of both, DCIS is late onset, it is more common. Synchronous invasive carcinoma percentage are more to 6%, and it is ipsilateral, and basic pathology is ductal carcinoma, ductal histological type. A suppose LCIS lobular carcinoma, it is a premenopausal into premenopausal. Multicentricity and bilaterality is important or significant thing. Subsequent development of carcinoma incidence is more in ductal carcinoma in situ. It is ipsilateral, but LCIS is bilateral, and histological type is, in both types, histological type is ductal carcinoma. Now we will see invasive ductal carcinoma. It is also called as non-specific tumor or not otherwise specified, serous or simplex, and it is more dangerous, invasive, and mortality is more than other malignancy. But unfortunately, 80% of breast carcinomas are these NOS type. Axillary lymph node metastasis are up to 60%, Peri and postmenopausal in both condition it is there. Peak time is 5th to 6th decade, solitary form mass, and 75% of ductal cancer showed estrogen receptor expression. Again, it is a favorable finding. Medullary carcinoma, it comprises 4% of breast carcinoma. BRCA1 phenotype hereditary carcinoma. It is soft and hemorrhagic. Rapid increase in size is common. Better 5-year survival than NST. Less than 10% demonstrate hormone receptor. Again, it is not a good sign. Mucinous carcinoma. 2% of carcinoma. It usually seen in elderly. Lymph node metastasis in 1/3 patients. 5 to 10 years survival rates are 73% and 59%. And over 90% mucinous carcinomas display hormone receptor. So basically it is favorable histopathology in old age. Again, papillary is a old age carcinoma, 7 decade, comprises 2%. Size, it rarely attains size of 3 centimeter, and survival rate is similar to mucinous, good survival rate. And again, gene expression is good, 87%. Tubular carcinoma, again it is a favorable carcinoma, perimenopausal or early menopausal, 2% of birth carcinoma. Long-term survival rate approaches nearly 100%, and 94% of cancer express estrogen receptor. Again, this is the favorable pathology. Invasive lobular carcinoma, it comprises 10% of breast carcinoma. It is multifocal, multicentric, and bilateral. The growth is insidious and difficult to detect earlier, but over 90% of the cancers express estrogen receptors. This is tumor grading or histological grading is again an important component while we are staging the disease and deciding prognostic index. This is the internationally accepted system defined by Alston and Ellis, assessed by evaluating acinar formation, nuclear size or pleomorphism, and mitotic activity. All components are evaluated in score of 1 to 3. So if total score is 3 to 5, grade is 1. In grade 2, 6 or 7, total score, and in grade 3, 8 or 9, total score is there. Depends on this grading system. There is a Nottingham prognostic index, the Alston-Ellis modification of Stark-Bloom-Richardson grading system. So combining these prognostic factors, this Nottingham prognostic index takes into consideration tumor size, lymph node status, and histological grade. So tumor size in centimeter multiplied by 0.2 plus histologic grade 1 to 3 plus lymph node stage 1 to 3, and total number will give you the value. Higher the value, worse the prognosis. So 5 prognostic groups can be divided, depends on this NPI. Excellent is if score is less than 2.41, 15-year survival is 84%. In good, less than 3.41, 15-year survival is 74%. Moderate one, 3.41 to 4.41, survival 63%. Moderate to 4.41, 5.41, 15-year survival is 46%. And poor if more than 5.41 score, and 15-year survival is 18%. So according to these groups, it will help in deciding adjuvant or neoadjuvant therapy. So adjuvant chemotherapy is not indicated in an excellent prognostic group and good prognostic group. But moderate prognostic group and poor group may benefit from adjuvant polychemotherapy. How this carcinoma spreads? So tendency to spread is first to bone, then lung and pleura, then abdomen, liver, peritoneal cavity, and at last brain. Before that, there is a axillary lymph node spread, supraclavicular lymph node spread, and skin metastases are also there. So breast carcinoma is considered as a systemic disease, not always, but majority of the time. How to diagnose? So their diagnosis includes our patient's clinical presentation and our examination findings. Consider differential diagnosis, investigations accordingly. Investigations we include triple assessment, biopsies, radiological investigations, tumor markers, immunohistochemistry, and nuclear medicine. So breast quadrant and breast cancers. So lump in breast and carcinoma, the frequency of carcinoma according to quadrant is the right upper quadrant is more highest 50%, retroareolar 80%, inner upper quadrant 15%, then outer lower quadrant, and at last 6% in inner lower quadrant. A breast lump or mass presentation is in 1/3 patient. Sometimes patient also present with only axillary mass and no breast findings. Occurring dimpling like skin changes, nipple discharge, retracted nipple, change in breast size, contour, pain, tenderness, redness, change in nipple position. Examination should be done thoroughly according to guideline, and patient must be evaluated simultaneously for metastasis also. So differential diagnosis consider fibrocystic conditions, fibroadenoma, intraductal papilloma, lipoma, fat necrosis, Mundor's disease, and thyroid tumor. Out of which Mundor's disease is a benign disease, but typically presents with thickened cord-like structures of superficial vein of chest with surrounding redness. Many a time it mimics inflammatory lesion or can confuse with inflammatory breast carcinoma. Thyroid tumor again has extremes, benign to malignant, rapidly growing tumor. So we have to consider. So if there is a breast lump, the histopathological examination is a very key element, and it must be done to prove that it is not malignant. We can investigate patient clinically. After clinically we suspect that it is a carcinoma. First, foremost investigations usually do FNSC or true cut biopsy, core cut biopsy or open biopsy, sentinel node biopsy, mammography, sonography, MRI, serum markers, immunohistochemistry, and nuclear medicine imaging. Triple assessment is a most important evaluation technique and is most effective and cheapest. It includes clinical examination, imaging with ultrasonography or mammography, and tissue sampling in form of FNSC or true cut biopsy. So positive predictive value exceeds 99.9%. First investigation, we usually, if patient present with breast lump, we suggest FNSC because it is very easy, very less discomfort and cheap. And best and diagnostic investigation is biopsy. Various types of biopsies are there: FNSC, true cut or core cut biopsy, excisional biopsy. There are few advantages and disadvantages of each technique. So FNSC is rapid, painless, and inexpensive, but problem is markers ER/PR are not routinely available, and false negative rate is more. True cut, core cut biopsy markers are available, but false negative results again is a problem. Excisional can be incisional biopsy, incisional or excisional biopsy. False negative results are rare. We can take piece of the tumor or whole tumor by putting incision and may serve as a definitive lumpectomy, but it is expensive, painful. It has incision and scar. We have to put incision in a way that it includes in future mastectomy if it turns out to malignancy. Sentinel lymph node biopsy is a very good tool, but not in routine practice since it is invented. But nowadays, it is very important component when we think about breast cancer in surgery. So based on the hypothesis, lymph flow is orderly, predictable, and tumor cells spread sequentially as from level 1, level 2, level 3, supraclavicular and internal memory. The sentinel node is the first node encountered by tumor cells. The sentinel node is the direct pathway of the primary tumor, on basis of which this practice is done. Advantages are definitely there. It obviates the need for axillary lymph node dissection without compromising staging and local control. So, if tumor is favorable, it is early stage tumor, we can save 60% of the patient from unnecessary axillary dissection. Disadvantages, again, there are false negative rate of 6% as compared to lymph node dissection 3%. And practically in this scenario, it is indicated in BCS only now. Another tool is mammography, basic investigations and prerequisite for BCS to know the multicentricity and multifocality, opposite breast screening. It is highly specific and sensitive. It demonstrates microcalcifications, asymmetries, spiculated masses, and linear branching carry the highest probability of being malignant. So these are the signs we can see here. Architectural distortions, appearance of a neodensity, maybe post-operative or post-radiotherapy. Axillary lymph nodes can also be detected, as we can see, by this mammography. Nodal features, we can comment regarding nodal features regarding malignant or benign. Say if absence of fat, change from oval to spherical size more than 2.5 centimeter in size, then we can consider it is a malignant node, but histological confirmation is essential. On basis of radiological findings, there is a BIRADS, breast imaging reporting and data system classification. It categorizes the lump and what action should be needed. So if category 0, 1 to 6 is there, most important is 3 and 4 category. So 3 probably benign findings, short-term follow-up is required. We must keep patient in constant follow-up and we have to confirm that it is benign. Suspicious abnormality, do biopsy and then confirm it is not malignantly. Otherwise, highly suggestive malignancy, appropriate actions should be taken, and non-proven malignancy, final treatment is given. Ultrasonography again is the adjuvant to mammography. Usually it is sonomammography. Ultrasonography is usually done with mammography, and it differentiates solids between cysts. It is useful in pregnant women. In non-palpable lesions, USA guided aspiration and pre-biopsy localization. Limitations are it cannot detect microcalcification, cannot differentiate benign and malignant lesions as mammography do. Another investigation is MRI with DTPA. It is a very specific investigation. It can detect less than 0.0 mm size tumor. Neoangiogenesis can be made out. Advantages are there. It can miss only 2% of tumor as compared to mammography 10% and USG missed 15% of tumor. But cannot detect microcalcification and it is costlier. So we cannot use it in screening or routine. MRI can be used when silicone implants have been used with suspicion of local recurrence. Certain serum markers are there, alkaline phosphatase when there is metastasis in liver, CEA, CA15-3, CA27-29. But these markers are not diagnostic markers. These markers are useful in recurrent disease so that it is not a pre-operative profile. Immunohistochemistry is an important landmark. Once it is developed, it changed the practice of management of breast carcinoma, and very specific management and non-surgical management is useful. ERPR HER2 status Ki67. So ERPR positive status more than 10 F-mol on ELISA or more than 15 S-score on IC predict improved response to endocrine treatment, time to relapse and overall survival. So these markers are positive, then these are the favorable findings while managing breast carcinoma for recurrence and overall survival rate. So there are luminal criteria. So LUM A, ERPR positive, LUM B, HER2, all positives, basal cell type, all negative, and HER2 type, HER2 positive. And by these markers, we can decide further management in form of chemotherapy and hormone therapy. Nuclear medicine is also helpful in diagnosis of carcinoma, but these are costlier affairs, so used not routinely, out of which 99M technetium sustainably detects less than 1 centimeter, used for stereotactic pre-biopsy localization. Another is a 99M technetium tetraphosphine. PET scan other than FDG, fluoroestridiol FES is very specific for breast cancer, for primary or metastasis and judge response to neoadjuvant chemotherapy. So we can conclude that after these all investigations and this presentation, there is a low incidence and high mortality in developing countries. High socioeconomic status is the risk factor, not otherwise specified variety of breast carcinoma. 80% component is there, and it is dangerous because prognosis is not so good. Staining mammography is advantageous. It causes 30% reduction in development of breast carcinoma, especially in ER positive patients more than 50 years of age. Triple assessment is the investigation of choice having predictive value more than 99.9%. Thank you very much for your time and patience.